Good afternoon, everyone. I hope you're all keeping safe and well. My name is Megan Stovall-McKnight, and I'm the Chief Operating Officer at the Princess Margaret Cancer Foundation. Today, I am so pleased to welcome you to an exclusive conversation with Dr. Gary Roden and Dr. Richard Sullivan, moderated by Dr. Keith Stewart. On behalf of everyone at the Foundation and the Princess Margaret Cancer Centre, I would like to begin by saying thank you. We are in an extraordinary time for Canadians, and in particular for cancer patients and their families. Cancer did not stop because of COVID, and neither did you. As some of our closest supporters, your commitment to help us continue to deliver world-leading cancer research and care during these unprecedented times is truly appreciated. As you know, our mission at the Princess Margaret Cancer Foundation is to raise funds that accelerate cancer research, education, and patient care benefiting patients at the Princess Margaret across Canada and around the world. This global impact is made possible through our international network of partnerships, collaborations with leading minds from over 500 institutions in 70 plus countries. And today we're going to talk about one of these global partnerships, the Global Institute of Psychosocial, Palliative, and End-of-Life Care, also known as the acronym GIPPEC. Our guests will highlight both the local and global influence of their work and opportunities on the horizon that will support universal access to palliative and supportive care. Now, before I introduce our moderator for today, a reminder that we will have time for an interactive question and answer at the end, and we would love to hear from you. You can submit questions throughout the session using the Slido that can be found in the session description below. Now, I'd like to introduce our moderator, Dr. Keith Stewart. Dr. Keith Stewart is our Vice President Cancer at University Health Network, the Director of the Princess Margaret Cancer Program, and is Regional Vice President for the Toronto Central South Regional Cancer Program at Ontario Health. He also holds the Richard H. Clark Chair in Cancer Medicine at the Princess Margaret. Now, Dr. Stewart began his career at Toronto General Hospital and then moved to the Mayo Clinic in 2005, where he was the Director of the Mayo Clinic Centre for Individualized Medicine. And we are absolutely thrilled to have Dr. Stewart back with us leading the Princess Margaret. Welcome, Dr. Stewart.
His microphone.
Keith, do we have you?
His microphone.
Oh, your microphone, Keith.
It had to happen. It had to happen. My apologies.
It's the words of 2021.
Okay.
You're on mute.
Thank you very much, and sorry about that. Well, let's start again. So thank you, Megan, and thanks to everyone for joining us this afternoon. I'm very happy to have the opportunity to be here for today's discussion on how Princess Margaret is shaping cancer care in the global context and continuing our status as one of the world's top cancer centers. This month, Princess Margaret is a proud sponsor of GIPPEC's Palliative Care Culture and the Clinic Symposium. And we'll ask Dr. Roden and Dr. Sullivan in a second about GIPPEC, but in brief, it is a partnership with other international academic centers. Its aim is to generate research that would inform public policy, health systems, and clinical practice in the area of psychosocial, palliative, and end-of-life care, and to provide education to enhance research and practice globally. These and other issues in psychosocial and palliative care of individuals with advanced and terminal disease require interdisciplinary expertise and global collaboration in order for them to be meaningfully addressed and for research findings to shape clinical practice, healthcare policy, and research delivery. I'd now like to introduce to you our guests for today and our co-chairs of the GIPPEC Symposia, Dr. Gary Roden from Princess Margaret and Dr. Richard Sullivan. Dr. Roden, who you'll meet in a second, is the Director of the Global Institute of Psychosocial, Palliative, and End-of-Life Care, or GIPPEC, as we've mentioned, and a Professor of Psychiatry at the University of Toronto. He is also a Director of the University Health Network Cancer Experience Program, a position we've recently created to bring more comfort and confidence to our patients, both in the physical environment, in their interactions with our staff, and in navigating their journey through the cancer program. Gary is well known to us. He's been at Princess Margaret for many years as a clinician investigator who has published widely on the psychiatric and psychosocial aspects of cancer and other mental illnesses. Gary has authored texts on depression in the medically ill and on the psychiatric aspects of transplantation. And he's currently leading research on the psychosocial impact of advanced and terminal disease in affected patients and their families. So welcome, Dr. Roden.
Thank you, Keith.
Also joining us today from London, England, is Dr. Richard Sullivan, a Professor of Cancer and Global Health at King's College in London. Dr. Sullivan is also the Director of the Institute of Cancer Policy and co-director of the Conflict and Health Research Group. His research group studies health systems, particularly non-communicable disease policy and the impact of conflict on health. As well as holding a number of visiting chairs, Richard is a NCD advisor to the World Health Organization. That's non-communicable disease advisor to the World Health Organization, civil military advisor to Save the Children, and a member of the National Cancer Grid of India. So welcome, Richard.
Thank you very much indeed, Keith. Wonderful to be here.
It's great to have you both here together, and I'd like to move on and ask you a couple of questions about GIPPEC. And just to ground our audience in what we're talking about here, Gary, do you want to just fill us in on GIPPEC, how it started, what the thinking was, and how you got to where you are today?
Yes, Keith. Well, I guess I could say that traditional medicine and cancer care has often been very focused within the four walls of a particular institution or within the more narrow frame of medicine. And what we've come to appreciate, firstly, is the problem of advanced disease and end of life involves many issues that are beyond, the more focused confines of medicine. They involve issues of religious faith, there's issues of law, there's issues of health policy. And we found that there's many investigators, academics, and scholars at the University of Toronto, all in separate silos and really not having a forum to collaborate with each other. GIPPEC was created firstly to create that kind of interdisciplinary forum to bring together clinicians, investigators, educators, and scholars to deepen thinking, to develop research, to create collaborative interdisciplinary research. Secondly, to develop a global outreach, to bring our knowledge to the world and to learn from other parts of the world how we can provide care better. And we've been able to do that successfully. We've developed an intervention for advanced cancer called CALM, Managing Cancer and Living Meaningfully, that we've disseminated to over 20 countries in the world. We're doing research in Africa. We're collaborating with the European group, the Palliative Research Centre. So I think we've gone a long way. And this symposium comes out of that spirit of interdisciplinary collaboration.
And how did you and Richard manage to meet up? Richard, what's the story there?
It's like all good stories. It starts in a strange place with an accidental meeting. Gary and I were both at the aortic meeting. This is the African Research and Treatment in Cancer meeting in Maputo and Mozambique, of all places. And I can't quite remember, I think maybe one of us was sitting down at the time and the other person bumped into each other. And we basically sat down and started talking about some of the marvelous things we were hearing at the conference, but also lamenting about the fact that so much about what we did in cancer research and health systems was only seen through the sort of Western biomedical lens. And what we really need to do was kind of expand things out to consider, as Gary said, elements of culture, of interdisciplinarity, of ideas which went way beyond what we normally think of when we think about classical cancer research. And it was that conversation in Maputo. From that moment on, we ran with it. And we've arrived at what has been an absolutely fantastic symposium, which still has one more day to run.
And so this obviously was the seed of the symposium. Gary, tell us about the symposium, what you hope to achieve from bringing these, and tell us a little bit about the membership. Who's at this conference?
Well, actually, it's gone beyond all expectations, Keith. We have more than 600 people registered from more than 60 countries. I couldn't begin to listen from you, but to tell you that they're from all over the world. We've had other people join us in sponsoring the concert, the symposium, the European Palliative Research Centre, the Dalhousie School of Public Health, Richard's group at King's College, he's brought on, and the Global Oncology Program at Princess Margaret, all of these and the Division of Palliative Medicine at the University of Toronto, all of these have joined in the sponsorship and planning of the program to bring it all together. And we began to think about how we could bring together people who would have something new to bear, bring to bear on the problem that we actually don't hear or see at traditional cancer conferences or even palliative care conferences. So we have quite a wide range, which we could tell you about, of academics from diverse disciplines who've helped us shed light on these problems.
Well, let me ask Richard. Richard, I gather there are some speakers from the United Kingdom. What are the highlights from over there?
Yeah, no, I'm luckily surrounded by some extraordinary colleagues in the UK that cover a really wide range of areas. Dr. Charlotte Chamberlain from the University of Bristol, who's been studying the aspects of decision maker and paying, the economics essentially, and decision making within palliative care. Professor Richard Harding from the Cicely Saunders Institute in my King's College London. And Richard's actually an anthropologist by background. That's how he originally trained. And Richard brings a very wide, diverse understanding of both clinical trials, but also interfacing social sciences and cultural anthropology into studies. And we've also been incredibly lucky to have the support and actually the input of Dr. David Collingridge as well. He's a visiting professor at my college, but he's also the editor-in-chief of the Lancet Oncology. And it's been extraordinary because Dave's an incredibly busy man, as you can imagine, running the Lancet Oncology, but has attended both days now and is attending the final day as well. And he's been a huge supporter, I think it's fair to say, of palliative and supportive care over the years with the many commissions he's put forward. So those are just a few individuals in the UK. But as Gary said, we've got this incredible range of people also attending, which crosses time zones. There are people who will literally wake up in the morning at 5 a.m. to people going to bed at midnight. So it really is kind of, Chile to New Zealand. So it's been an absolutely extraordinary. I personally have never seen a conference with such a diverse range of people from as many time zones. So fantastic.
Gary, you're both oncology focused. Is the GIPPEC restricted to oncology, or is it broader than that?
It's broader, Keith, but in palliative care, one of the things that's emerged is that much we've learned about palliative care has begun in oncology. Cicely Saunders, who's considered the mother or the grandmother of palliative care, began focusing in London in that way. And a lot of the lessons have been learned from oncology, but we're now beginning to apply them to a whole variety of other illnesses because these are the same issues in end-stage lung disease and end-stage heart disease, neurological disease, so that it's spread out to all advanced diseases.
And what would you see as, apart from the fact you've obviously had a tremendous response from around the world to attending the conference, what would you see as the important consequences of what you've done and the follow through on it?
We have our final day, tomorrow, so I could give you more of the answer tomorrow, but firstly, we've been just struck with the degree of engagement and interest that there is, people beginning to talk to each other who've never talked before. And we're going to develop a plan that follows from the symposium that's going to involve bringing groups together, developing collaborative research, and developing a different kind of partnership. Christian Mitsamira, who was one of our speakers, he's a surgeon and a palliative care physician in Rwanda, the executive director of the African Center for Research and End-of-Life Care. He began with the provocative title of Decolonizing Palliative Care. And I think what he's referring to is the attitude of high-income countries that they could simply come and impose or teach their attitudes, their approaches to palliative care to very different cultures. So we've begun this kind of dialogue, and we're going to begin to learn from each other. We've also learned that in countries like Africa, they have many approaches to psychological, spiritual support, and non-professional caregivers, for example, that we could learn a great deal from. So we need to think more about bilateral exchanges in research rather than just one country teaching or helping the other.
I'd like to dig into the detail a little bit more for the audience. I'm sure they're dying to get there. But just before we do that, as a practicing oncologist myself, there's been a clear shift, it seems to me, from palliative care being solely focused on end of life to I'll say move to the left of the equation, which is to intervene earlier and to, I think in some randomized trials, even show that you can improve survival by doing so. I'd like both of your thoughts. Maybe Richard, is that a fair judgment, or what do you think about the movement in that direction?
Certainly. I mean, I should declare the fact that I'm one of the great unwashed surgical community. So when I started practicing in the early 90s, I can tell you that, you know, palliative in supportive care was not really taught at all. It was hardly considered. So what we've seen over the years is enormous strides and bounds actually from palliative supportive care, from the research community. I think the work you're alluding to was, I think it was Jennifer Trammell's work, New England Journal of Medicine, showing that good palliative care was actually improved overall survival. So we tend to focus all the time on new drugs, new forms of radiation, new surgical treatments, but actually just better palliative care, delivering better palliative care, alleviates suffering and indeed prolongs life. But I guess stepping away a little bit from this, part of this conference is also expanding things out and asking this question that, you know, dying and death is probably the most personal aspect of someone's life that they have some aspect of choice over within their cultures. And the uniqueness we're getting out from this conference is absolutely extraordinary because it's so diverse. We often sort of pour all this into the same bucket. So you mentioned the point about decolonizing, Gary mentioned about decolonizing. The reality is most of palliative supportive care is often seen through the biomedical lens. And what we're getting from the conference, of course, is the cultural and the social layering here, which reflects very differently, and it actually speaks to a very different research agenda as well, I think. A much more mixed methods approach, integrating social and economic sciences with what we consider to be classical clinical trials. And I think that's come out really, really strongly. The strengths, for example, of qualitative research, when we're often very focused, for example, on quantitative clinical trials. So I think for me, that's what's really excited me about this, is it expanded the horizons of research. And I think it's also expanded the horizons of how we conceptually look at the whole of palliative and supportive care through these very different cultural lenses.
Is there a country or system within a country that really struck you as getting it right, or at least having created something interesting and different enough that we should be studying it more closely, or is it that too detailed?
Well, I mean, there are some countries that have better outcomes, that have more well-developed palliative care than others. Each of the countries, I think, has its own limitations. I would say one of the things we've learned from our research in Africa, we've shown that actually end-of-life care, the quality of dying and death, is better in places like Canada, where we have more access to palliative care, when we speak about symptom control of physical symptoms, access to morphine. When we look at psychological support and spiritual well-being, death anxiety, actually countries like Africa do as well or better than we do, actually, with much less resources. So we have something to learn about how to use non-professional caregivers, about family and community support, and about the responsibility of the community as well as hospitals. So I think that's the kind of bilateral exchange that we're talking about.
You know, that in the briefing notes, I picked up on that maybe you could expand on a little bit the notion of maybe in Western society focusing on the patient, and in other societies focusing more on the family and the support systems, and maybe to our fault, we haven't focused enough on the caregiver in this story. Gary, what are your thoughts on that?
No, I agree with you. In a way, the family they're even more invisible because nowadays, because of COVID, that they're less present in the cancer center. But I think we have this idea that it's an individual patient's problem, whereas we know that it's a problem for the whole family when someone has a serious cancer, and that the major source of support for people with serious cancers is the family. We want caregivers to manage people, manage their partners. We want them to be able to keep them at home for as long as possible. But Keith, we don't do enough as a country, as a government, as a healthcare system to support caregivers for their families and to help their families in their home. And Christian Nitzamir, who I mentioned, put it an interesting way. He said, when you're well, you belong to yourself. When you're ill, you belong to your family. And I think that's very true. And we don't do enough to support the family. I would say through our Cancer Experience program, which we'll talk more about at another time, that's one of the things we hope to emphasize. How can we help not just patients, but families through the whole cancer trajectory?
Richard, how's the National Health Service doing in the UK in terms of managing palliative care? And since you're kind of poster childs for lockdowns and COVID variants, how has COVID impacted the whole field?
I mean, let me put hand on heart and say that it's been one of the most difficult experiences, I think, for most of our professional lives, watching the impact of COVID-19 across the UK. And I don't want to sort of go into long details of mismanagement and lockdowns and the spread of the virus, but the reality is that most of what's happened has caused enormous suffering, I think, to our cancer patients. It hasn't been formally studied yet, but I think if you had any palliative care or other oncologists on the line with us now, they would tell you that it's been extraordinarily difficult for the whole of the palliative care groups, but also, of course, for the families as well, many of whom have been completely locked away from patients in the final hours or days of weeks of their lives. And that's something we haven't really overtly talked about. And I think the problem being is, of course, it's about numbers. It's very easy to count mortality, excess mortality due to stage shifts of cancers because of delays in diagnosis or delays in treatment. It's been much harder to really study the suffering that's been intrinsic, that's been across the board. And I would argue as well, you know, from our perspective, it's bereavement as well. What we hear from a lot of my patients is how difficult the bereavement process has been afterwards, not having been there in the last hours, the small levels of the funeral. And it also talks something else Gary talked about, transculturalism. We think of, you know, maybe sort of going to Africa to learn about Congolese beliefs in dying. But if you take somewhere like London and our area, we have nearly 72 different ethnic groups now that we look after, all of which bring their own belief structures and cultures to the, you know, the act of dying and death in terms of palliative care. So actually, in terms of reflections that we've learned here is, I think COVID-19 has really exposed how these different communities grieve, how they handle palliative care in terms of the overall structure, and just how important it is. But I can honestly tell you, we haven't really studied this properly at the moment, and it needs to be.
Gary, I know we're drifting away from the conference a bit here, and I do want to come back to that. Was this discussed at the conference at all? And I suppose as a follow-on to Richard's comments, are there lessons learned that we can use to improve how we do things in the future from this sort of dreadful pandemic?
Yeah, very much. I mean, the pandemic, I think, has brought the world closer together as a global community. We've realized that we need to be understanding attitudes towards health and healthcare and the provision of healthcare and the access to supportive care and palliative care from each other. So I think that's one of the important things. I think it's also drawn attention to many of the psychological and social dimensions. We know that the burden of this disease, COVID, and the impact is not equally distributed. It's affected lower income people and lower income countries in a much more adverse ways for a variety of reasons. So it helps us understand that. And also how to take, as Richard said, how to take cultural factors into account. And one of the things I want to mention, though, it's not just the culture in the countries we're talking about, it's also the culture of biomedicine. I might mention that Eric Finkelstein, who was one of the speakers, who was an internationally leading health economist, began with a provocative statement. He said, "Hope clouds people's judgment." And that statement refers not just to patients, it refers to doctors. In the study that Richard mentioned, Jennifer Temmel out of Boston, when they showed that people who got early care lived longer than people who got usual cancer care, and this was at Harvard, Dana-Farber, the ones who lived longer got less chemotherapy. And so that we know that sometimes chemotherapy or other aggressive treatments get prescribed because doctors are uncomfortable having difficult conversations. And sometimes the comfort zone is to prescribe another round of treatment, even though it may not be what is optimal care. It's also very costly. So we have this happening. He was talking about accidental and intentional, what he called it, overtreatment. It's very costly. And then we have the fact that the least expensive intervention in the world, which is palliative supportive care, is underfunded in all places, in all parts of the world, even though places like organizations such as the WHO and the UHN consider it a basic human right. So this is the kind of problems we're trying to address. How do we bring people together to shift health policy, to shift attitudes within medicine, and to see that comprehensive care is provided rather than this, as Richard's saying, this kind of more narrow biomedical approach, which is what medical school has trained people mostly to provide.
Yeah, I think this is a very important point for the audience that, I think for many people trained in oncology, we've been trained in the era of chemotherapy, and when you don't have any more chemotherapy, it feels like you've exhausted your usefulness. And to some degree, palliative care was, the choice of last resort for those people who felt everything would be fixed by chemotherapy. But that's changing rapidly, of course, and the realization that involving your teams much earlier in the courses is actually highly beneficial. And as you all know, one of the I guess the theme of our vision for moving forward is to move beyond chemotherapy and to eventually eradicate that to the dustbin of history, even though for now it is clearly beneficial for many patients despite its toxicity. Folks, I want to drill down into the conference a little bit deeper now and just learn a little bit more about some of the other things you've been talking about. Gary, you opened the conference with a phrase that caught my attention, the palliative paradox. Do you want to explain that? It sounds very psychosocially.
No, it's not really psychosocially. It really relates to what I've said, so often, and Keith, you've heard me say this in Princess Margaret too, I advocate for more palliative and supportive care. And in many parts of the world, I've heard people say, well, gee, how could we afford that? And yet we know that it's a very, very small percentage of the total cost of cancer care. And in many diseases, there's certain cancers that we know, to back up, we've made progress in many cancers. In some cancers, unfortunately, we haven't made much progress in terms of extending survival. And palliative and supportive care might be the most important and most effective treatment that we can provide. And yet cancer centers across the world feel they don't have money to support this. Now, we know that it's not about resources. It's not about money. It's about attitude and value. To what extent do we value this? And this conference is partly to bring people together to have a single voice, to say, this matters, this is important. Everyone wants the best cancer care, but we also want to help patients and families manage as well as they can. And when we talk about early palliative care, by the way, Keith, it also means that we're helping people live with the condition, not just how do we help them die well, but we now have people with more extended survival, and how do we help them live their lives as well as they can, as well as managing cancer and the challenges of treatment. And that's a task that we have to help people with.
Richard, how is to Gary's point, is the in those countries where palliative care is not prominently promoted as part of their health system, is it financial? Is it cultural resistance? Is it what's the reason you think that it's not caught on fire in other countries?
I think there's a mixture. I think part of this is simply the base. And when I talk about that, I mean that there are simply not enough healthcare workers, and there are not enough healthcare workers dedicated to cancer. So that's one part of the problem. That is a reality across many parts of the low and middle income spectrum. So putting that to one side, I think the other big factor as well in many countries is one of culture. Medicine is seen as about, particularly in cancer these days, is about the art of cure. And in cultures where you're dealing with individuals dying, in Arabic we would call it haram. It's a kind of forbidden thing to go into. The other aspect is what that always comes up is the money aspect here, which is, as Gary alluded to, palliative care is not funded in many countries, even those countries that may have reasonable social insurance systems. You take AGE in Mexico, it's very popular in Mexico, AGE in, say, Chile, the new Ayushman Bharat program in India, for example, is a good idea. Very little palliative care is funded through the Ayushman Bharat program, which funds vast amounts of, in inverted commas, curative care. Now, if you've got an economic system set up to only support X, doctors and hospitals will tend to follow only X. And that's at the hospital level. At the individual level, of course, if you want to make a living and do private practice, you'll make a great deal more money by doing medical oncology, radiation oncology, and surgery than you will becoming a pure palliative care doctor. And so there's a financial disincentive at the individual level. So in a sense, this is 101 behavioral economics. And Eric Finkelstein, also alluded to that in his talk at the conference. So I think these are factors all work together in concert to drive, if you like, down the difficulties on developing palliative care. And I think often I think we need to be a bit more realistic about how we deal with this and a bit more honest about tackling some of the really complex issues like getting palliative care into social insurance models and social insurance support. And I talk from a country which also poorly funds palliative care through NHS tariff systems. And that is a disincentive as well for recruitment and for funding areas. So those are broadly speaking, the issues.
Gary, what are the solutions, if there are any?
That's a very good solution. Well, I think gathering evidence is one of the things. I think research is an important thing. We got to have local evidence. I think, but evidence we know is not enough to change policy. So there needs to be a vigorous approach towards advocacy. I think that, and we need to have it be a collaborative international effort.
How is Canada doing in this sphere? I mean, you're obviously a beacon of hope here, but how is Canada as a country doing? Do you think we do a good job compared to others?
Well, I think, maybe to quote Dickens, we could say it's the best of times and the worst of times. I think that we do very well in some centers. I think Princess Margaret, for example, didn't 20 years ago, but it now has a very well developed palliative supportive care program. Large majority of our patients get access to palliative care. But as a country, I don't think we can say we do as well as we should. A large country that's geographically dispersed, and we don't do nearly as well to people in remote regions, but we also don't do nearly as well for marginalized groups. Keith, and one of the speakers at our conference was Carrie Barassa. Carrie is the CIH, the head of the Canadian Institute of Health Research, Institute of Indigenous People's Health. And she talked about the problem of mistrust within the Indigenous community of traditional healthcare providers, including in palliative care. And she and other people in our center have said the same thing, that we need to do more to understand that culture and to build trust, to attend to their needs, which are unique and specific, and to have them feel what she referred to and has been referred to as cultural safety. And we hope in our own center, Keith, to draw through the Cancer Experience Program, to draw a lot more attention to the diverse needs of different cultures, including the Indigenous and other marginalized groups.
Yeah, one of the jobs I inherited when I moved back to Toronto in June was, as part of my portfolio at Ontario Health, is the Indigenous Cancer Program. And it's actually been a joy, to tell you the truth, getting to know that community and understand a little bit about their perception and also their very real challenges in navigating entry into the system, which is often as simple as having a place to stay while they're getting their cancer care and having a way to pay for that. So that it's actually been a pleasure joining with that community. Richard, this global partnership is good. How do you see this evolving, and where do you think we can take it?
Well, I think on its most basic level, what it's managed to do is pull people together from such diverse backgrounds. I have absolutely no doubt out of this is going to come a lot of really interesting projects, research programs, collaborations between individuals, and I think I'd like to think this is going to be the seed for some really exciting sort of multidisciplinary research now. And I also like to think it's a springboard. Larry alluded to the importance of advocacy, a springboard for more advocacy, both on the supranational level at World Health Organization, at individual national levels. Christian, for example, in Rwanda, being able to use this to continue to advocate for palliative care there, but also as a way of, I think, potentially re-engaging some of our wider community. One of the things we've been dealing with as well is this idea of integration. And it's not just simply integration between the different disciplines, it's between the different methodological disciplines. I think it's an integration of palliative care back into the wider cancer care community, be they surgeons, medical oncologists. And I think this will be really, really helpful for being able to do that, because we'll be able to give them a kind of new offering, a new way of thinking about things. And I'd like to think that would be a really big help. And certainly we'll be looking to do a lot of advocacy, I think, going forward, and really supporting the palliative care organisations that have joined together in this conference to really get to the right policymakers in the right way. Absolutely crucial if you're going to change minds and actually improve the funding and resourcing of global palliative care.
It sounds a little ivory tower if I was to be an armchair critic. How do you involve the voice of the patient or the customer?
Well, simple as this is, you've got two things here. First of all, I'm surprised, but I was amazed at how many people have logged on to the meeting who come from outside the healthcare professional community. You know, these are members of the public, they're individual patient advocates who have joined together. I think one of the core things we actually haven't done brilliantly well is engaging patients and public. And PPI involvement actually, although we think we're starting to do it reasonably well, Canada's been a leader in this for many years. We're starting to improve in the UK and Western countries. But I can tell you, if colleagues from Rwanda were here, or Zambia, or even India, they really, really struggle with this whole public and patient involvement. And I think it's one of the really crucial areas to develop. And I don't think it's just true for palliative care, actually. I think it's generally for cancer research. And I think that's one of the potential big areas, particularly because this is so strongly about family. This is one of the few areas where you can really reach out into families and communities, into things that really matter and engage them. Whereas in many countries, what you see is very sophisticated biomedical sciences, and the families and communities are very much on the outside rather than the inside.
I've jumped around a bit in our questions, and I just want to make sure I've touched on all the areas of interest you thought have come out of the conference that the audience might want to hear about. So Gary, other comments on the conference, interesting concept you heard of that we haven't yet highlighted?
Well, one of the things that follows from what Richard said, and we're going to hear a lot more about it at the final day of the symposium tomorrow, is about the integration of palliative and supportive care into oncology and into medical care. Palliative and supportive care is built upon the voice of the patient in the sense that it's all about trying to improve the patient's experience, trying to relieve pain and suffering and psychological distress and planning for the end of life. It's within medicine that we need to make that voice heard. So palliative care and supportive care has to not be a standalone thing, which is extra or marginal or optional. It has to be seen as central and part of palliative care. So we need to influence the leaders, people like yourself, the leaders in palliative care, in oncology, to see this as a core component of cancer care and care of other medical conditions. So I think that's the next step. We're going to hear a lot about that tomorrow. What are the strategies to integrate it? You know, in all centers of the world, Keith, including our own, we're still seeing people not referred early enough when resources are available. And it's tragic.
That made me think of another question, which maybe I'll give to Richard, which is, you know, the delivery of this care has still focused around cancer centers. What is the role of the primary care practitioner and other allied health?
Well, they're extraordinarily important, but again, we run into this foundational issue here at the moment as the increasing divergence between comprehensive cancer centres, tertiary care, away from cancer centres at the secondary level, away from primary care. And these are, if you use a sort of tectonic plate analogy, at speed, on speed, I should say. These have been moving away rapidly for years and years. So certainly when you look at a lot of systems, we do have a problem with the integration of tertiary and secondary care for cancer with our primary care colleagues. And that, I'm going to be honest with you, from my perspective, extends all the way to palliative and supportive care as well. We certainly in the UK, we need a completely different approach to integrating into primary care. We have a fantastic primary care system. They're often cut out of the loop, even to the point that, you know, we'll be engaging with hospices with our patients, and the primary care physician, he or she will not know that their patient is currently in a hospital at the end of life. So I think we have some structural and organizational issues with engaging with primary care. They're essential, but that's something to be done. And to be honest with you, in other countries, many of the low middle income countries do not have a primary care system in the way that we have in the West. And so the models of community engagement there with healthcare workers who do standard practice need to be very, very different from the way that we think about it in Western countries.
You know, I was just reflecting as you were speaking about the fact that when we write our notes in the clinic, we tend to send them back to the referring oncologist, and sometimes, hopefully, to the primary care physician, but often that information isn't even available to us. So it immediately creates this, they don't even know maybe their patient has cancer and is getting treatment. Gary, I feel the seismic shift is moving, the tectonic plates might start coming back together, to use that analogy, because I do feel like one thing that's happened with COVID, if there is a silver lining, is we've learned how to deliver care virtually much more efficiently. We've accelerated things that were taking years to deliver care in the home. And by a consequence of that would obviously be that we'd have to more deeply engage the primary care and nurse practitioners working in the community. So perhaps that's an opportunity. Any thoughts on that?
Yes, I think that is the silver lining of this pandemic. It's made us realize, for one thing, we are part of a larger health system and we need to connect with, integrate with for the benefit of our patients so that they can navigate through it. We have learned about virtual care. Our conference, Keith, could not have happened in person because those 600 people would not have been able to afford from many parts of the world to come to the conference. We would have not been able to bring all of these speakers together. So we've been able to connect the world and connect with the world in a way that we wouldn't have before. And we hope because of that, answer to your question, what next? The thing that Richard and I really didn't want was for this to be an interesting conference and then everyone go home and go about their business as before. We wanted this to be a springboard for action. So we are going to create a framework for research, for collaboration, for action that will follow from this. And it's going to involve bringing all these players together. And it does include the makers of health policy in government and in other healthcare provider organizations.
Well, thank you both. It's time we probably moved on to the question and answer period, because I'm sure the audience has got lots of questions for you that are much better than mine. So if we could perhaps go to the Slido part of the presentation and see any questions that have come in from the audience. All right, so let's dive into these. What can be done to support the families and loved ones of those who are dying? It seems to me that the patient's experience is better if their caregivers are also helped to cope. And Gary, I think we've sort of addressed this, but why don't you tell us a little bit about your thoughts and how we're going to implement this?
Well, our own research has shown, by the way, that there's actually much more distress in caregivers than there is in patients, and for many different reasons. We need a systematic approach, to help caregivers and families. Some of it is information that they need about their condition and about the treatment and about the resources that are available to them. Some of it is involving them in decision-making and providing support along the way in the trajectory to help their distress, to provide them with information and provide support through the whole experience. That makes a difference both to patients' outcomes and also to those of family. So we're beginning now, Keith, both with the online versions and in person, to develop a more systematic approach to caregivers, to the support of caregivers. We really haven't had before. It's been very sort of random in a way, based on who happens to seek help rather than in a systematic way. We know many people need help who don't know how or where to ask for it.
Richard, I'll turn the next question to you, and I'm going to ask the third one here. In your career, and I assume you've been in your career for 20 years or longer, what advancements in palliative and supportive care have you seen that were most significant?
Quite a few, actually, and credit to where credit's due here. I think the ability to manage symptoms, to intervene with often really distressing symptoms, either through medical, radiotherapy, or surgical interventions, has grown exponentially. So symptom control has been absolutely fantastic. I've been really impressed with the advanced planning now that goes on. It's far better than it ever was when I certainly qualified in the late 80s. The ability to, although there are enormous disparities around the world in access to opiates, there's no doubt that there have been improvements in the last 20 years in the access to opiates and pain relief per se. If you were to look 20 years ago compared to now, in a lot of countries has improved. That's not to say in many places it's not still a big problem. I'm going to say the actual nutrition and feeding elements, certainly I was a GI surgeon originally. We were really important in the way we looked after our end of life and rectal or colon patients. For a variety of reasons. And one of the things we never did properly was feed them properly. Now, nowadays, the treatment interventions is fantastic there. And I will say, I think the efforts of people like Gary, Richard Harding and others, the advocacy and the idea of palliative and supportive care being integrated into the wider oncology practice is light years ahead of what it used to be 20 years ago. And that's been a really, really big plus. And that's a very subjective thing. It's very hard to see it from the outside. but that's what you see. And I would say around the world, maybe places like India, the growth in places like Palliative India, the advocacy, the acceptance of palliative and supportive care into the National Cancer Grid of India has marked an absolute sea change from attitudes 20 years ago, which wouldn't have even talked about this, never allowed these individuals into the same room to do national cancer control planning.
Thank you for that. Gary, let's make it local here rather than global. What are the top 1 to 3 near-term actions that Canada and or Princess Margaret could take? So this is your golden opportunity to tell our audience what you're going to be doing.
Well, I think one is access. We know that in spite of the fact that we have a public healthcare system, we know there is not equal access to high quality cancer care. So I think that's a problem we have to fix, and to see that that all people get equal access to high quality cancer care and to palliative and supportive care, both in order to get into the cancer center and also to have access to the resources in the cancer center. So I think access is one. A second would be the provision of supportive care and palliative care as part of routine cancer care, something that's considered as a central part of all cancer care. And that involves a process of availability of services, but also having a system within the cancer center to see that those kind of referrals occur. The third thing is education and training. And that's focused on the healthcare providers. I think we need better training at the level of primary, secondary, and tertiary care in control of physical symptoms like pain, and in managing psychological distress. And Keith, one of the things that we do very poorly is train doctors and healthcare providers in how to communicate with patients. We kind of train doctors to do many other things so well, and we assume that they know how to do that intuitively. And we know that that's not true, that they require training, they benefit from training. And we're about to begin to develop a communication skills training program. It's going to have an in-person and online version, which we believe should be part of standard cancer training of cancer care healthcare providers, both at Princess Margaret and really throughout the world.
Gary,
I could say more, but you've limited me to 3.
Gary, you tell us all about the Grand Challenges program you just launched, and I know it's in the scope of the Cancer Experience program, which you'll be talking to the foundation about later. But just tell the audience a little bit about that, because I think that was sort of encouraging. Yes,
well, this is something that's been initiated at Princess Margaret, the Grand Challenge grants, and the idea is to fund novel, bold ideas which can have a transformative effect on cancer care. And they've been to do with cancer treatment, with chemotherapy, with technology. And with the formation of our new Cancer Experience program, we created one on the human touch in cancer care to fund novel research that would change cancer care, that would improve the experience for patients and families. And Keith, when we began, we didn't know what the response would be, but we've received 27 different applications from our cancer center, all from multidisciplinary teams, all with really outstanding novel ideas. We're not going to be able to fund them all, but we have a rigorous review process, and we're going to try to move as many of them forward as we can to have a transformative effect on cancer care, both locally and beyond.
Thank you. Richard, over to you here for this one. How do you think attitudes have shifted amongst our medical colleagues, oncologists and hematologists, who treat cancer daily in regards to dealing with mental health, psychological and emotional issues caused by cancer alongside a pandemic?
It's interesting. This is again a purely subjective view here. One of the things we've noticed from the pandemic is, of course, human suffering, isolation, loneliness have come into stark relief for everybody. Gone are the days where you could hand off the issues of palliative care if you were a medical oncologist or clinical oncologist or surgeon. Now they're there constantly in the back of your mind, and particularly because of the issues about not having patients, family members around them when they're in hospital, issues of transfers to hospices, etc. So I think it's come from front and center to most of the other healthcare professionals involved in cancer care. How people have reacted to it, I think, has been extremely variable. Some people have really embraced it in the sense that they've started to really appreciate and understand supportive and palliative care and the wider psychological and emotional support and issues that are needed. I think others, it felt like, I'm going to use the rabbit in the headlight. They're kind of stunned. And then we have a group which are kind of still rejected. They've kind of walked away. They still don't want to deal with it, despite the fact that it was faced with them day to day. I would like to think, as Gary said, this is a silver lining, that out of this we get much, much better at understanding and dealing with palliative and supportive care in the wider cancer community, not just the specialists who work within our particular centres. And I'd like to think that, we would have an opportunity to do something about it. Attitudes have shifted, and I think they've shifted positively for the majority of our colleagues, but we still have some islands of resistance, if I may use that phrase.
That's a great answer. Thank you. And one thing I would reflect on is that one thing that's happened in the pandemic is the caring of our staff for each other has dramatically changed. I think there was very little attention paid pre-pandemic to how your colleague was feeling on a particular day, or your nurse was feeling, or what might be happening in their home life or with their children who can't go to school. And I think the pandemic, as Gary said, has brought countries together. It's also brought small communities together. I think in our own cancer centre, the amount of time that people spend thinking about their colleagues and how they've been impacted, and if your doctor's not happy, your nurse isn't happy, your cancer patient isn't going to be happy. So there's, I think, been a very healthy growth in that, I'll call it empathy, within the cancer centre itself. It's a tough job, as we all know, and it is stressful, and at times people do tend to wall themselves off and sort of compartmentalize things, but that seems to be, again, if there's anything good out of this awful experience for everybody, it may be that might stick beyond the end of the pandemic. We have one question left, and it's a very appropriate one on which to end, and I'm going to give you both a chance to reflect on this. Gary, where do you anticipate the field of palliative care heading in the next 10 years?
Well, I could say what I anticipate and also what I hope, but I think we're going to see that this whole area becomes less stigmatized. People are more willing to talk openly about it. I think the integration of palliative care with oncology and with other medical fields is where we see it's going to be headed. It's going to become much part of routine cancer care. I think we're going to try to make use of a broader multidisciplinary approach. The earliest casualties of cancer are actually not due to the cancer, they're suicide. This large epidemiological study shows that the suicide rate goes up 12-fold in the first week after the diagnosis of cancer, and that's just due to fear. We don't do enough. We don't make use enough of a whole range of health professionals which could support patients from the time of diagnosis. So I think making use of a multidisciplinary team and providing this continuity from the time of diagnosis to the end of life and in bereavement. And also, as I said, not only that we shift it earlier, but that we help people live as well as they can when time is short, not only to plan for the end of life. Those are the things which I think will be part of routine cancer care. We'll no longer have to advocate for them in a way that we do now.
Richard, over to you.
Well, I just say, as a reformed surgeon who knows when to stop, I'd like to just entirely agree with Gary, being the expert in this field. I think is absolutely spot on. I would completely concur with everything you said.
I'm going to end with something controversial, Gary, and I know you won't like it, but it's kind of part of my persona, so I'll do it. There's sort of a connotation of palliative care and end of life being inextricably linked. And I've often asked my palliative care colleagues whether a rebranding and a relaunch, it wouldn't be helpful in terms of building support for earlier introduction and destigmatizing it to a degree. And I wonder how you react to that.
Well, it's an interesting thing because, as you may know, the word palliative or palliative care was coined by a Canadian, coined by Balfour Mount. And it was coined to avoid the stigma associated with the word hospice, actually. So, but the greatest difficulty is actually not in patients. Almost all patients accept palliative care when it's explained to them what it is. And it was originally entirely to do with end of life, and there still is this association. So it does require an educated process for people to understand that it's about psychological, physical, social, spiritual care from the time of diagnosis. But I don't know if it would surprise you or not, Keith, to know that the greatest barrier is not in patients and families, it's in physicians. That the barriers to referral come from doctors, actually.
Right, that's part of my question. I wonder if, you know, I don't know what the name is, transitional care or just supportive care even, would remove that sort of historical bias.
There's been debate about that in the field. It hasn't affected access. I can tell you that our referral rates continue to grow in places where they change the name and where they haven't changed the name. My only concern, apart from the name itself, is that it shouldn't be to avoid difficult conversations. And we know that is the biggest problem. We don't train doctors about how to manage their own discomfort when they have these conversations and how to conduct them in a way that's compassionate and that helps people sustain hope. I think that's the biggest problem, because actually the name is really not the problem. The problem is the challenges these people are facing, the disease, the threat to their life, not actually the name.
Well, thank you both. It's been a very enjoyable conversation. I hope the audience has enjoyed it. Richard, we particularly want to thank you for taking time out. I know it's getting into the evening there in London, and we appreciate your help. And I hope you've been vaccinated, or if you're not, you will be soon, and that we can move on from this. You probably have more vaccinated than we do out in Canada, where we've got none right now. Gary, thank you for all your efforts on behalf of Princess Margaret, of the palliative care community, and bringing this to the world. I think is a logical next step for a cancer centre that wants to have global impact and global presence. I'd also like to thank the foundation and invite Megan if she has any closing comments. And also the audience for joining us today. We can't see you, unfortunately. We assume you're there, and I hope you've enjoyed our conversation. And perhaps with that, Megan, I'll hand it back to you to close us out.
All right. Thank you so much, Keith. Thank you, Dr. Sullivan. Thank you, Dr. Roden, for your wonderful remarks. What a fascinating hour it's been. And thank you to all of our supporters who joined us today and submitted such thoughtful questions. I hope everyone has a safe week and stay well.